I have to say I'm really delighted that you've given me this opportunity to come and talk to you about what we're doing in policing, because actually I think the links between policing and health need to be and are stronger now than they've ever been. We are all in very difficult austerity times. We are all given a plethora of new priorities and new performance indicators that we have to meet. But at the end of the day, we are all dealing with vulnerable people. And I think that's where we have huge similarities in some of the challenges that we have, but also some of the help that we can provide for each other to improve the service that we deliver. So first of all, my name's Chris Jones. I'm a commander in the Metropolitan Police, and I've been in the Met for 29 years. I took over the mental health portfolio about 4 years ago. And the reason that I did that was twofold, really. That the first thing was that I have a responsibility for boroughs in North London, as well as a number of other portfolios. And 4 of my officers were stabbed and one very nearly killed by a gentleman who was suffering from a mental health crisis, who went into a kebab shop, picked up an extremely sharp knife, and when the officers tried to restrain and detain him, 3 of them were stabbed. 1 of them had his bowel severed, and if they hadn't been wearing body armour, we would have been dealing with murder. So when I started to look at that case, I realised that this was a service user who had come down from up north. He'd had a long history of mental ill health, a long history of crisis. He'd arrived in London. He'd been arrested once by the police as a result of an incident in the street where he'd assaulted a member of the public. What bothered me was that we knew absolutely nothing about him. We knew nothing about his history. We knew nothing about his vulnerabilities, and we certainly didn't know that he was somebody who fairly frequently was suffering from psychotic episodes as a result of failing to take medication. Sounds familiar, doesn't it? And I felt then that there was something slightly wrong with the relationship between policing and mental health, and policing and, health professionals. So I started to look at what was the involvement of policing with mental health, and I was, have to say, pretty shocked. I started to look at how many people were taken into a police cell with mental ill health, and I can tell you that in the last year, we have reduced the number across the country by 1/3. But when I first started to look, there were over 10,000 people a year being taken into a police cell as a result of mental health crisis. And my sense was, well, where's the ethics and the morals in that? If you've got a broken leg, you go to hospital. If you've sprained your ankle or if you've broken your finger, you go to hospital. But it's acceptable that if you've got a mental ill health crisis, you're dragged off in a police van and thrown into a police cell. How's that work? How could that possibly ever be right? And you probably are aware that there have been a number of really tragic, horrific incidents where families have lost loved ones at the hands of police officers who have been restraining them because of mental ill health, because of their behaviours, in circumstances, frankly, that I think the police should be nowhere near. So I started to really just pull all this apart and think, well, what is the role of police? What are we here for? And I've come up with a number of issues that, frankly, and thank God for so many health professionals who kind of get this themselves. We're here to look after people who are vulnerable. And I think the biggest job of the police is to protect the vulnerable. There is a huge overrepresentation of people with mental ill health as either victims of crime or in the criminal justice system. 86% of sentenced male prisoners have got a history of mental ill health. So what does that tell us? What that tells us is we're putting people through a justice process who probably need something else. We're probably putting people into cells who shouldn't be there. And actually, where's that parity of esteem between having a physical ill health issue and a mental ill health issue? Nobody would accept somebody in a stroke or having had a broken appendage being taken into a police cell. So how did we arrive at the place where we think it's acceptable for somebody with a mental ill health crisis to go into a police cell? And if we look back at legislation, and this is, I guess, a bit of a political point, and I'm not saying this on behalf of policing, this is my own view, but if we look at the Mental Health Act when it was first introduced in 1983, what do we know was happening in 1983? What was happening in 1983 was the fairly large-scale closures of mental health institutions. And at that point, the police get a power of arrest under Section 136 for people who are in immediate need of care and control. Coincidence? I don't know. But I actually think it's a very weird situation that somebody who has a clinical need is able to be arrested in order for that clinical need to be dealt with. And my personal view in a civilised society is that that is unacceptable, utterly unacceptable. So that's kind of one thing. And then the second thing is, and this will be pertinent absolutely to all of you, is when do police officers use restraint for people with mental ill health and where? And there are a couple of very, very high-profile cases that you will know of where people have been restrained in a mental health environment by the police and died. Now, there are a number of issues there that I think are really just dreadful. Dreadful for the officers who have been there and their families, dreadful for the staff in the hospital, but worst of all, dreadful for that person and their family who would have believed that they were in a safe place being treated because they were ill. And somehow they have ended up dead as a result of being restrained. Now that cannot be right, can it? It just cannot be right. So I then started to look at what is our role? Why are we called into mental health environments? Why do we end up restraining people with mental ill health? And it seems to me that there is a practice that's built up over quite a long period of time simply through a lack of investment and a lack of training, where on the one hand, Royal College of Nursing and others talk about safe restraint and safe restraint practice, absolutely right. And they talk about the most, the least restrictive methods of restraining someone, absolutely right. And they also talk about non-pain compliance practices, again, absolutely right. What's plan B? That'd be us then. And this is what I discovered, that you guys are working on the front line in an area where actually there is a predictable risk, I would suggest. Not massive, because contrary to common culture, I absolutely do not believe that most people with mental ill health are dangerous. I think most people with mental ill health are like us in this room. They just need support. There are very, very few people who are so dangerous that actually mental ill health should be regarded as dangerous in broad society. But I'm afraid the culture is that, and we've got to debunk that culture. But actually, at the times where somebody is perhaps very challenged in their behaviours, what tools are available to our health partners in order to tackle that? And what advice are you being given professionally, as opposed to the type of advice that police officers are given? Because police officers, you know, do regularly restrain people. We handcuff them. We deal with some very violent, nasty people. But I don't think we have a role in going into mental health institutions to effect a restraint that somebody else is not prepared to effect because they lack the capacity, capability and training to do it. Now, I've talked to lots of health colleagues about this, and there's a real difference of opinion, to be honest. Some health colleagues say, well, actually, we don't think we should ever get involved in that kind of level of restrictive practice because it damages the relationship with the patient. I get that. But actually, hang on a minute, that patient is part of society, that actually at some point they may need to call on police to support and help them because they're in crisis. Because frankly, have you ever tried to call an ambulance if you're in a mental health crisis? They'll tell you to call the police. So we know that we will encounter people in crisis. We know that we will need to have the skills to do that. But I don't think that's the same as having the skills within a caring environment to bring somebody down out of crisis, which I think is a really, really intricate and detailed way of looking at somebody's history, their triggers, and understanding their broad histology before you try and approach the problem that they're presenting. Because all we'll do is come in, great load of police officers steaming in, flatten the person, done, job done. Really? How would you feel if that was one of your family members? The police officers don't want to do it. The patients are terrified by it. The staff are confused by it. So actually, fundamentally for me, the whole issue of how people are dealt with and the training that's provided to staff within that health environment is utterly and profoundly inadequate. And more importantly, it's different in different areas of the country. There's no consistency about training in relation to restrictive practice. There are lots of different professional opinions. And that's quite right, because we should be challenging ourselves all the time to find out on the basis of evidence what is safe and what isn't. But it can't be right that the nursing profession and psychiatrists on the one side say that a particular practice is safe or unsafe and won't be used, and then expect the police to use it because nobody else will. We shouldn't be using it either if that's the case. To this end, then, I've actually started to look at the ethical position of police officers going into that environment. And we are working at the moment with Lord Carlisle. I hope people have heard of Lord Alex Carlisle. He's a real advocate of ethical policing, and I have got a huge amount of respect for him. He has really challenged policing over the use of stop and search and a whole range of other sort of accepted practices over the years. And he's a real humanist as well. You know, he understands the context and the environment. And Alex Carlisle is chairing something called the Expert Reference Group, which is comprised of people across the health sector, across nursing, Royal College of Psychiatry, NHS England, NHS Protect. You name the elements of the NHS, and God, there are a lot, aren't there? Everybody is represented, and the idea is that we will come up with a joint plan that will not only identify the role of police, but will also start to support frontline staff in the skills that they need to be able to deal with what I, as I say, think is a fairly predictable challenge in the environment that they're working in. Mental ill health, we know, is an increasing issue in society. There are lots of reasons for that. I'm not sure we're really clear about what the triggers are. You often hear anecdotes about the deterioration in the environment, in sort of social mobility, in terms of a whole range of other issues, but I'm not sure that the evidence base is as sound as it could be. And I think you heard this morning about how important data is. For me, I think there are real big issues for us in health and in policing to present the right level of data to indicate the demands that we are facing as a result of mental ill health. Because I personally feel that if we could collectively, and I mean collectively across the whole of public sector, effect some sort of a joint strategy to reduce vulnerability, we would start to carve out the really expensive crisis end services, because we would be redirecting through identifying vulnerability at its earliest stages. We all know, don't we, that it's actually much cheaper to have a local community psychiatric team who are working with a manageable caseload than it is to have lots and lots of extra crisis management beds, because that's the really expensive end of the business. So we should all be thinking about how we're going to turn that crisis tap off if we can't invest upstream. And I think that's where collectively the data that we all have in different pockets has got to be so important to inform the joint strategic health needs analysis, and therefore the commission services that are provided by local authorities, by safeguarding bodies and by mental health trusts in local communities to make sure that they properly reflect the level of demand that you are facing. And when it comes to restraint, I actually think the real professionals and the real people that we should be talking to and listening to about how best to restrain and deal with people with challenged behaviours are yourselves. And it shouldn't be that you are restricted either by practice or training so that you get to a point you cannot cross and you have to call the police, because I personally think it's unethical and it's not our job to be going into a health environment in those sorts of circumstances where actually somebody is just in need of help. And we wouldn't be doing that in any other area of medicine. So I'm going to stop there because I'm really conscious of time, and I should imagine there's probably some of you are thinking, what a load of old rubbish. But I really do want to give you the opportunity to sort of challenge me or to ask me questions or whatever else. So thank you for listening, and please feel free to ask any questions that you have.
I think you present a very compelling argument there. I have to say, I think you've oversimplified the scenarios. You know, I think most people who've got a broken leg or some kind of physical health problem usually aren't under the influence of substances and want to fight the world. And I'm not suggesting for 1 minute that everyone with a mental health problem is like that. But I think the reality, especially in acute mental health care, is that nursing staff these days are having to deal with people that are in that kind of situation. You know, I'm interested that you haven't mentioned the memorandum of understanding between the NHS, the APO and the CP, Crown Prosecution Service, around how assaults on health service staff should be treated.
Yeah, I agree.
I mean, we had 60,000 assaults on NHS staff last year, and that figure is rising every year. Very locally, in our trust, we had 323 assaults on staff by patients last year, and on only 20 occasions did we phone the police. And when we phone them, we expect something to happen, you know, because whether you're in a hospital or whether you're outside in a public park or wherever, if you assault someone, it's a criminal offence and it should be treated as such. And where people, and there are safeguards for those vulnerable people, where people have the capacity to understand their actions and the consequences and to go through the criminal justice system, then they should. So I disagree with you in the sense that there is a role for police officers in mental health, definitely, because very often that level of violence, when it reaches to that point, is above and beyond what nursing staff are trained to deal with. And that's where and thankfully where I live in Stoke-on-Trent, we've got a police force who, at the moment, are willing to come in and work with us and help us to deal with those situations that for nursing staff are very frightening, in all honesty.
I absolutely understand that. I think there's two really important points. I think you've hit on something in respect of the propensity for police not to investigate crime that relates to people with mental ill health on the assumption that the CPS will not proceed. And I think there's a real issue about that. And I absolutely agree with you. Unless there is clear evidence of a lack of capacity, and that's usually, statistically, probably only 8% of cases lack capacity, there should be a presumption that the criminal justice process will pursue justice. I absolutely agree with that. But that doesn't mean to say that the treatment for whatever is wrong discontinues. And the problem that arises is that we often find that an incident has escalated to the point where either somebody has managed to arm themselves or become so violent and unmanageable, for a lot of reasons. The assumption is that the police will come in and remove that person and put them in a cell. I argue, how is a cell an appropriate place for somebody who's in that condition? So it's not, I absolutely agree with you, we should be working hand in hand to tackle some of the violence. I think it's utterly unacceptable that people who are working to support some of the most vulnerable in society are suffering that level of assault. One of the things I would say, though, is what are the trusts doing around their health and safety responsibilities to make sure that the environment in which you operate is a safe environment?
Therein lies another issue.
So, absolutely right it does. And if that safe environment means that you need additional support in order to cope with what is a predictable risk, if you talk about 60-odd thousand assaults a year, I would suggest that violence in that environment is a predictable risk. So if it's a predictable risk, there is a strategic responsibility by the health authority, i.e. the trust, to make sure that there are health and safety, I suppose, mitigants in place that enable you to continue to operate in a safe environment, including your patients and those who visit. So whilst I absolutely agree that there is a role for police, I think the role that the police have undertaken is much broader than it should be on the basis that there isn't the capacity, capability and training to deal with the sorts of violence that you talk about. And when it does happen, how often is there a really good and solid and, I suppose, continual learning programme that prevents it from happening again? Because that, again, I think that joint kind of critical incident review is a really good way, your serious untoward incident process, a really good way of starting to get in and under that. And actually, a lot of those assaults probably should be scrutinised by the Health and Safety Executive to give you that support. I mean, NHS Protect are really keen to become involved and support staff to look at trends and patterns. Because you'll find, across the country there are some units that never ever, or very rarely, seem to have staff assaulted. And there are others that it's really prevalent. Now, I don't know what that data is, but do your bosses? Because actually that's the sort of data they should be looking at. So, well, there's something about either the environment, the clientele, because there are parts of London where there seems to be a much higher propensity for people to be, for example, drug psychotic than in other areas of the country and other areas of London. So actually that's a different risk, and it's probably going to require a different level of training, perhaps a different capacity, and a whole range of other things that mitigates that risk for staff. That does not mean it's a police matter, but what absolutely is a police matter is to properly investigate and properly support colleagues in health when they do become victims of crime. And again, one of the sort of messages and issues that I'm pushing forward across policing is that there is never an excuse not to go into a mental health institution to report crime, because that's what we're here for. We report, we investigate, and we proceed with crime. But it doesn't mean that on every occasion you've got a challenged prisoner, or challenged patient rather, that they're going to become a prisoner and be taken away, because they still require that treatment. So I think I'm actually furiously arguing absolutely the same point. Hi.
No, you're saying that in Merseycare we do quite a lot of work with the police, and we have our streetcar, which we just got from them for 6 months. So I do quite a lot of training with the police to explain what things like we have a mental illness and you are challenging and I am challenging. We heard this morning, and we have a pilot with our police officers in our units, because I asked our service users how do they feel about that. And most of it was positive. I didn't actually like the idea of a police officer being on the ward. I think that could challenge.
I don't either.
No, I didn't like it. And a lot of people said they didn't like it, but some of the ladies on the ladies' ward actually felt safe if they were in a mixed unit. Whatever, because there's lots of individuals there, and I don't like that word. There's a lot of people in there that display different behaviours, and it can be scary. I know it can be scary when that happens. But we've had a conversation with Merseyside Police, and they've had service users talk to them about what it's like to be in a 136 suite. I've been picked up by the police and I've been dissociated. Fortunately, I can't remember what they did to me. I wouldn't have remembered. But I know they got me to a place of safety, which was the ward. In the end, the police officers decided themselves that they didn't want to be in uniform. They wanted to be part of the team. And I think during that process, they learned an awful lot. I'm very mistrusting of the police. I really am. And I do try. And I think through education, the police will start slowly to understand how they can manage people like me and see past people.
I agree. I mean, one of the things I think that we've not been consistent about is identifying vulnerability. It's interesting, a few years ago, when I sort of first started to work on mental ill health, my sister's a consultant psychiatrist, and she specialises in learning disability. So, you know, if ever I start to talk about things she doesn't agree with, she jumps all over me because she's my big sister and I've got to be careful. And she told my mum, of course, so that's never good. But she started to say to me, well, look, you know, it seemed to me that every single kind of serious incident involving the police usually resulted in the police need training in. And we got to a point where the list was almost inexhaustible of all of the different mental health disciplines, all of the different mental health, I suppose, experiences, from learning disability all the way through to, you know, deep psychosis, that police officers need training in this. And I said to my sister, look, Kath, I've got this list. How could I get my staff trained, and how long would it take to give them something meaningful around all of these different disciplines? And she said, well, about 32 years. Okay, I'll give that one up then. Because actually I don't want my police officers to be trained to understand different elements of mental ill health. What I want them trained to do is to recognise vulnerability and then to know what to do about it. So we've worked with the University of Central Lancashire on a really fantastic model called the Vulnerability Assessment Framework, which is a really simple model that every single police officer in London at the moment, but it will be a national approach, every single occasion with every single member of the public, go through a very simple model of A, B, C, D, E to identify one, vulnerability, and then two, where does this person need to go? Who do they need to see now? But I think we need to go on the next step, which is if we encounter people who are vulnerable, how well connected are we with colleagues in health to say, well, actually, this is John Smith. He's well known to mental health services. He's got a care worker. This is the number that they're on. This person does not need care and control now, but actually if they're left, they'll probably deteriorate, so we need to get a referral now. How soon can we get that kind of joined up? Absolutely.
We have mental health practitioners, we
Yeah.
have police officers working together,
Yeah.
and you know, it's amazing because they have the information we need about me.
Absolutely.
So they
Absolutely.
and the people that are in the car probably have Nurse Smith.
Absolutely.
And working together, that reduces time in A&E.
Yeah.
It reduces people having to go back into units, and it addresses the problem straight away.
And it reduces fear for you as well.
Yeah, and it also reduces the fear for police that we're going to have.
Yeah, I mean, I do think that you know, street triage, I think, is a fairly common term that's used to describe the sort of the joint deployment that goes on between police and mental health staff. I think there's huge value in it, but I would also say we really ought to be asking the question: why do we need street triage? We need street triage because the pathways into mental health support, unless you are at absolute crisis, are very, very tricky. There's not enough of it. There's not enough of it at the right level. And that's why I think together, working together, we can properly reflect. If we get our data right and if we get our principles right, we can properly reflect what the demand is. And that's a very difficult argument then not to be able to have with the Department of Health about where resourcing needs to go in order to reduce vulnerability and support those people who need help, both in crisis, but actually more those who live with mental health on mental ill health on a daily basis. Absolutely.
Can I just pick up just on one thing, just in response to the discussion about assault? my personal view is if you have got high incidences of assault in any area, certainly if I was a head of an NHS trust that had high levels of assault, I would be wanting to look at Kevin's public health model of what's going on in relation to why there are so many assaults, who's being assaulted, when they're being assaulted. And it's all about the data-informed practice. It's hugely important, because that would concern me greatly if I was a chief exec and I had high levels of assault against staff. I'd be wanting to know what's going on and what's going wrong.
You know, 300 is particularly high.
It's high enough.
If you look at, no, in comparison to if you look at when the NHS Protect report comes out this month, I think, and what they do is they break it down, because obviously trusts are all different sizes, and they break it down by per 1,000 head of staff or something like that. But also, you know, we were talking in our session before lunch about the importance of incident reporting, and a lot of those assaults are very low level, what we call clinically related. You know, so maybe people who lack capacity for lots of different reasons, and often when you're trying to give care to people, I guess dementia services might be one example. And so it sounds high, but when you think that, you know, my assumption about 20 occasions where we've involved the police is that out of those 300 odd, there were 20 where perhaps staff considered there was a criminal element to it, and the others were related to the person's clinical condition.
I mean, I think you've got to agree what your tolerance level is, frankly. And when it goes beyond that, you are the best, frankly, people to judge whether or not an assault has occurred because it's a malicious act, or whether it's entirely clinically related, and you should have processes for that. But I think the lower your tolerance is, the better, really, because it improves practice, certainly in terms of your own safety and the training that you and your teams have provided. I've got about 2 more minutes left, so are there any other questions? Hi.
Yeah, I just want to ask about, we've heard a lot about organisational change, top-down approaches. We're very, very keen to look at bottom-up approaches, and fantastic presentation this morning from Iris, which I think represents that. But I think the other thing is, and I work in university, so I train student nurses. And I think there's an issue around expectation and boundary in terms of professional practice. And I think what we talk a lot about in healthcare education is multidisciplinary interprofessional education. And we're not great at it, but we know it works. And we know it works really well in terms of working with people who have varying conditions, varying vulnerabilities. And I'd just be interested to know what your views are on kind of bringing together newbies, new professional, nurses, doctors, practitioners, and new police officers at the National College in relation to working together. Because that's fundamentally what we're talking about. We're talking about working together and about understanding those boundaries, those expectations, about supporting, you know, the stuff that you do with youth and around identifying vulnerability. I'm a learning disabilities nurse, and I work predominantly in the community. So when we're talking about hospital-based provision, actually, my clientele have far fewer beds in terms of specialist care in comparison. So therefore, my clientele are actually members of society. From the moment they get up to the moment they go to bed, they're not necessarily detained, they're not necessarily in a hospital environment, they're living in their own home, and may well be presenting with that level of complexity in terms of predictable risk that requires an intervention that is far beyond what a staff team may be expected. And there is a high level of social care staffing within learning disability care who don't necessarily even have that professional background and experience and support.
Well, I think there's two things there. I mean, bearing in mind that there is now legislation around adult safeguarding that didn't exist. And the Social Care Act has made really clear what's expected in terms of support to those who are regarded as vulnerable. But I actually think that behind that is a massively hidden demand about just how many people are living in society who have those sorts of vulnerabilities, where safeguarding, even if they don't necessarily meet the statutory threshold, they actually require safeguarding support in order to prevent them from being involved in crime, or more importantly, victims of crime, because there is a disproportionate number of people who live with mental ill health who are victims of crime. So I think the idea and the concept of looking differently at vulnerability, and if that's done as a group of professional practices, then yeah, why wouldn't we? But I think you've got to have a framework by which to do that. And I'm just trying to think what the other point you made was, which was kind of about the education piece. I think probably that's what's going to come from some of the work that we're doing with the expert reference group, because, I mean, for example, this afternoon, or this evening rather, Frankie's going to attend the National Award ceremony for the Royal Nursing Times. And actually we're hoping, really hoping, that South London and Maudsley receive an award for a joint DVD training that they did with us, with the Metropolitan Police, around restraint and mental ill health. So actually, you know, that some of the frameworks are there, but I think we need a strategic framework as well, by which there is a presumption that we all work together, we share information, but actually we bolster one another's positions around demands. And I think your demands are massive. I think they're increasing. I think they are under-assessed, but I don't think there's parity of funding, and I still don't think there's parity of attitude towards mental well-being and mental health in the way that there should be, and the only way we're going to do that is to work together. So thank you very much indeed.